صباح الخير. أنا رانيا، مدرس مساعد جراحة أطفال في جامعة عين شمس. حابة أكلمكم النهاردة about a brief guide to the diagnosis and the first line management of some common neonatal surgical emergencies. What are some common presentations in the neonatal period which may have an underlying surgical cause? Vomiting, abdominal distension, and respiratory distress. First of all, vomiting. When a neonate comes with vomiting, I have to ask myself, is it bilious or non-bilious? Is it associated with abdominal distension? And at what age or what day of life is the neonate presenting? First of all, if there is bilious vomiting, any otherwise healthy neonate attending or arriving with sudden onset of bilious vomiting at any age, malrotation must be excluded. Bleeding per rectum may also be present in cases of malrotation. However, it is considered as a late sign or a late presentation. If bilious vomiting is during the first few days of life, then I should think of an intestinal atresia, especially if there is a history of polyhydramnios, such as a duodenal atresia, where the atresia is after or beyond the ampulla of Vater, so that there is bilious vomiting, or jejunal atresia. If bilious vomiting is associated with abdominal distension, then I have to think of a lower level of intestinal obstruction, such as distal ileal atresia, meconium ileus, or Hirschsprung's disease. In Hirschsprung's disease, there is going to be, in about 90% of cases, there is going to be a delayed passage of meconium beyond the 48 hours in most of the cases. Okay, so next, a patient with bilious vomiting and is stable to go and perform an X-ray. I'm going to perform an abdominal X-ray. If this is what I see, which is a single air bubble with a gasless abdomen, then immediately I have to think of malrotation with volvulus on top. If I have time and my patient is stable, I must undergo an upper GI contrast study, which is the golden standard for diagnosis of malrotation. Here I'm going to find the duodenojejunal flexure, which should be normally on the left side of the spine. In cases of malrotation, it is going to be on the right side. If there is volvulus on top, I could see this picture of a corkscrew appearance, indicative that there is volvulus on top of malrotation. So here I reached my diagnosis, malrotation with volvulus on top. If I have time, I can perform an ultrasonography. What I'm going to find in a case of malrotation is inversion of the relation of the superior mesenteric artery and vein. Normally, the vein is on the right, but in cases of malrotation, there is going to be inversion of this relation. In cases of volvulus, I might find a whirlpool sign where the superior mesenteric vein and the root of the mesentery twist around the superior mesenteric artery, giving the sign of a whirlpool sign. Okay, a neonate presenting with bilious vomiting in the first few days of life. I ordered an X-ray. This is what I got. This is a diagnostic double bubble sign of duodenal atresia or duodenal obstruction. Sometimes after I have inserted a ryle, it is not quite clear to me if there is a double bubble or is it maybe malrotation or volvulus. What I can do is, first of all, I could just simply inject some air into the ryle, repeat the X-ray. If it is a double bubble, then it is a duodenal atresia. If not, it's still questionable for me. I'm going to also perform an upper GI contrast study. This is how it's going to look like in cases of duodenal obstruction. A dilated duodenum followed by a level of obstruction. So here I have reached my diagnosis of duodenal obstruction. Okay, if this is what my X-ray looks like, here what I can see is a dilatation of proximal bowel loops, also with no distal aeration, but it is multiple dilated proximal bowel loops. So most probably this is a jejunal atresia. What if the neonate is arriving with bilious vomiting along with abdominal distension? So now I'm thinking most probably about a low level of intestinal obstruction. Again, I'm going to order an X-ray. In these X-rays, I can find dilated loops all over the abdomen. In the neonate, it's a bit difficult to tell whether it's small bowel or colon because the hausturations are not easy to see as in the older age group. So right now with these X-rays, I can't really tell which type of low-level intestinal obstruction it is. In this X-ray, there is a small hint to the diagnosis, which is the soap bubble appearance, which we can see. This occurs in cases of meconium ileus because they have very viscid mucus. Along with the air, it forms gas bubbles that give a soap bubble appearance, and so this could be a clue to the diagnosis, which is a meconium ileus. Okay, so I got any of the previous 3 X-rays with the bilious vomiting, abdominal distension. The patient is stable. Next, I'm going to perform a water-soluble contrast enema. If this is how my contrast enema looks like, here I can see a microcolon, a disused colon, and the contrast did not fill any of the dilated small bowel loops. It just filled a disused colon. So here I have reached my diagnosis of an ileal obstruction. What if I performed a contrast, and this is my finding, where there is a transitional level between the proximal ganglionic segment and the distal aganglionic segment, then this is a diagnosis of a Hirschsprung's disease. This is what I'm suspecting. If this is what I receive on performing a contrast enema, again, there is a disused microcolon. However, in this X-ray, some small bowel loops are seen, but they are filled with filling defects. These filling defects are the inspissated pellets of the meconium in cases of meconium ileus, and so here I have reached my diagnosis of a meconium ileus. If during performing a contrast enema, this is what comes out of the rectum, and then the patient is clinically doing well, then I have reached the diagnosis of a meconium plug syndrome, and usually there's nothing further that I need to do for this patient. What do I have to keep in mind when I'm doing a contrast enema? That I should not inflate the balloon during performing a contrast enema as to not cause a risk for rectal perforation. Also, any patient undergoing a contrast enema, I have to adequately resuscitate this patient to avoid any hypovolemia that, along with the distension caused by the contrast medium, may lead to ischemia of the bowel. Okay, so now that I have reached my diagnosis, what is the first line management? In cases of malrotation, any symptomatic patient with a positive investigation for malrotation needs urgent laparotomy, of course after resuscitation. If I'm suspecting volvulus, then immediate exploration must be done. Any delay in the operative intervention for any further confirmatory testing or any prolonged resuscitation is discouraged once the suspicion of volvulus is achieved by clinical grounds. Intraoperatively, what we perform is a Lanz procedure. Okay, if I have reached a diagnosis of a duodenal obstruction, what is next? I have to exclude any associated anomalies by performing an abdominal and a spinal ultrasound as well as an echo. Next, patient is ready for an intraoperative intervention. Okay, if I'm dealing with a case of jejunal obstruction, it is not as mandatory as in duodenal atresia to perform other investigations for associated anomalies, because the pathology of jejunal obstruction is thought to be a vascular insult that had happened in the intrauterine life, and so it is not as mandatory. And then the patient is also ready for surgery. Okay, if I'm dealing with a case of Hirschsprung's disease, I have to perform gastric decompression by an orogastric or nasogastric tube, rectal decompression using rectal irrigation, and there are 2 pathways. Either the patient is going to respond well to the rectal irrigation, the parents are going to learn how to perform rectal irrigation, and they must be warned about the signs of Hirschsprung associated enterocolitis, as it may be fatal during the waiting period until their surgery, and a patient can be discharged. Those who fail to respond to rectal irrigation might need to undergo a leveling stoma during the neonatal period. Sometimes the initial presentation of a Hirschsprung's disease can be a cecal perforation, and of course that is going to be treated as an emergency operation. In the neonatal period, we can perform a bedside suction biopsy to further confirm diagnosis of Hirschsprung's disease by histopathological diagnosis. However, unfortunately, it is not available at most centers in Egypt. Okay, if I've reached the diagnosis of a meconium disease, I have to exclude the association of cystic fibrosis by performing a sweat chloride testing. Most probably in simple cases of meconium ileus, the contrast enema is going to be sufficient, it is going to be therapeutic, and most probably I'm not going to need anything further. I might use N-acetylcysteine solutions, whether orally or through rectal irrigation, to dissolve the rest of the upper GI secretions. In cases with complicated meconium ileus, which may present with a perforation, an atresia, a volvulus, a cyst, most probably I'm going to need an operative intervention. Okay, what if I have a neonate coming with non-bilious vomiting? Again, I have to ask myself at what day has the neonate arrived? If it is early in the first few days of life, then I can think of a duodenal atresia, where the atresia is above the level of the ampulla of Vater, and so the vomitus is not bile stained. Another rare condition is pyloric atresia or a pyloric web. If the patient is presenting a bit later in the neonatal period, of course, it is important to exclude all medical conditions, but a surgical condition I have to keep in mind is the hypertrophied pyloric stenosis. It is going to be most probably starting from 2 to 8 weeks of life. The vomitus is going to be projectile in nature, and if I'm lucky during examination, I will feel a small mass, which is known as the olive sign. What's next? An X-ray. If it is vomiting in the first few days of life, non-bilious, this is how my X-ray looks like. It is a pyloric atresia. If the patient is arriving, starting 2 weeks of life, projectile vomiting, this is how my X-ray looks like. I have a distended gastric bubble. Then most probably I'm thinking of pyloric stenosis, but I'm going to perform an ultrasound. In an ultrasound, the diagnostic criteria for a pyloric stenosis is to have a split muscle thickness of more than equal to 4 millimeters and a pyloric canal length of more than equal to 16 millimeters. What if it is still questionable, the ultrasound is still equivocal, I'm not sure, I can perform an upper GI contrast study in selected cases. What I'm going to find is the string sign, or the part where the pylorus is hypertrophied. Only a small string of the contrast is passing through this hypertrophied pylorus, and so I have reached my diagnosis of pyloric stenosis. It is important to understand that hypertrophied pyloric stenosis is not a surgical emergency. However, its resuscitation is of utmost priority. If the patient enters an operation without being adequately resuscitated, it may lead to a post-operative apnea, and so operative intervention is only done when the patient is well resuscitated. Another clinical picture or another complaint that might have an underlying surgical cause is respiratory distress. What are the clues that might lead to me thinking that there is a surgical cause? In congenital diaphragmatic hernia, most probably the neonate is going to have a prenatal ultrasound saying that he has a congenital diaphragmatic hernia. In cases of esophageal atresia, there's probably going to be polyhydramnios, and there might be other associated anomalies such as an anorectal malformation or any limb anomalies that may be a clue to having an esophageal atresia. Okay, so if the neonate is first few days of life with respiratory distress, signs of respiratory distress, and I am already thinking of a surgical cause, what is the first thing to do? I have to pass a Ryle. If this is how the X-ray looks like, the Ryle is coiled in the upper esophageal pouch and not reaching to the stomach, then this is a case of esophageal atresia. Of course, here we have aeration in the abdomen, and so this is the common type where there is a distal fistula with esophageal atresia. So now I have reached my diagnosis of esophageal atresia with a tracheoesophageal fistula. If this is the X-ray that I see, then I can say that this is a congenital diaphragmatic hernia. Most of them, 90%, are posterolateral, and 80% of these are left-sided. Okay. So an esophageal atresia, what's my next step? I'm going to perform an echo, not only to look at other cardiac anomalies, but also to detect if there is a right descending aorta, which is present in 3% of cases, because it is going to differ with the surgeon with the approach of surgery that he may use. I must also order a renal ultrasound and spine radiographs or ultrasound and look for any associated malformations, look at the anus, look at the vertebrae and the limbs. The initial management involves putting the patient head up, lateral position. Some suction must be started into the upper esophageal pouch to suction all the saliva and prevent any aspiration pneumonitis from occurring. If there is respiratory distress, go for endotracheal intubation and ventilation. Do not use forceful bag mask ventilation, because this in turn is going to distend the stomach through the distal fistula. It might lead to diaphragmatic splinting or even gastric perforation. In congenital diaphragmatic hernia, what am I going to do? Also an echo. Here it is important to look for congenital diaphragmatic hernia associated pulmonary hypertension. It is important also to understand that congenital diaphragmatic hernia is a physiological emergency and not a surgical emergency, so it is important to initially stabilize any cardiopulmonary distress. Also, most of cases will need an endotracheal or respiratory support. It is also better to intubate rather than use a mask ventilation, because a bag mask ventilation is going to increase or is going to distend the stomach and the intestine and cause further respiratory distress. What contributes most to the overall survival rate of congenital diaphragmatic hernia is the presence of pulmonary hypoplasia, the degree of the pulmonary hypertension associated with congenital diaphragmatic hernia. This is the end of my presentation. I hope it was useful, and thank you for your time.